go ahead and get started. The link, I think it's on the WhatsApp group. So thank you again for joining us today to talk about clinical research in general, with a focus about meta-analysis and systematic review. Today we have the pleasure to have Hazem Ayesh again. Hazem is an MD MPH. He obtained his MPH from Johns Hopkins and did residency at the University of Toledo. Currently, he is endocrine fellow at the University of Vanderbilt. Hazem, you can take it from here.
Thank you, Dr. Alter, for the nice introduction. Thank you so much for the kind words. So we're going to start today. I'm going to try to to share my screen very quick. And yep. So is it okay? Everything is feels good. So yesterday we discussed some kind of study types related to clinical research, and today we're going to talk a little bit about one or two other types, and then we're going to talk about some practical steps to help start the process and prepare you for the next few sessions. So we're going to talk about the randomized controlled trials, which is one of the most interesting study types, and it is one of the probably strongest evidence based medicine studies. So what are the basics? The basics, the first thing, it should be random allocation to study or placebo group. In other words, using the vocab from yesterday, random allocation to exposure or no exposure. And in this case, we decide the exposure. We introduce the exposure for the patients and controls. Second, it's set random here. So, and also you have to be cautious here because not all clinical trials are randomized controlled trials. There is some clinical trials, what we call open label. So the patient can decide which group he or she should go to. So not all of them are randomized. So here we are talking about the randomized ones. And the second component of it, it's blinding. And the blinding can be part of any level. Like it can be at the patient level, it can be also at the investigator level, and also it can be at the analyst level. For example, if the patient may not, like in theory, they should not know if they are in the treatment group or they are in the control group. And the second thing, you as investigator or researcher who is conducting this study, ideally also you may not know if the patient in the treatment group and in the control group. And the reason why we are doing all of this, to avoid bias, because if you know upfront where the patient is, in which group the patient is, then you're gonna start to assess the patient in a different way. So you're gonna use, this is what we call the bias, like treatment of the different groups, not in the same way, like you are treating them differently based on your information. And this is the bias. So to eliminate the bias, we have to try to use this blinding. And the randomization at the very beginning, the reason for it, to eliminate confounding, because if there is a confounder in the study, it's going to be equally distributed among the treatment group and the control group. So you will still have a confounder, but it is in both groups. So once you have a trouble, like you have a confounder in both groups, that will help you to make a conclusion, because there is no differences between the treatment group and the control group. Both of them have the same number of confounders. And this is why we use the randomization, to make sure that both of them, they have the confounders, so the confounders will not play a role in the conclusion, because there is no difference in the two groups and the confounding. So this should not affect the results of the study. And you have a zero, you start, like you allocate the patient into your two groups, and then you start to follow those patients for a time period. It might be days, years, months, depend on the kind of study. For example, if it's a feeding study, like you are introducing diet, this is going to be a short trial. If it's a like terminal cancer study, it's going to also a short trial. If it's antihypertensive medication, it's going to be a longer trial. So depend on the intervention, depend on the resources, depend on the study population, the research question, you decide the time of the trial. And the good thing about it, and we'll talk about this later, it is important, it generates relative risk. And this is advantage. Actually, to have a relative risk number is a very important advantage, actually. So here is a demonstration. You start by randomization first. So you're gonna randomize your patient, and there's randomization. Then it should be treated group and non-treated group. Then you follow them over time. So this is time component. And then you see the number of events or outcome in the treated group or the exposure group, and the number of the events or the outcome in the non-exposure group or the non-treated group. So here we use the same vocab. There's an exposure, there is outcome, and there is study population. All those three main components of any research, some kind of refresher from yesterday. So, and one may ask actually a question here. Let's assume that some people decided to option out of the study along the way. Like they say, oh, I will not follow up with you anymore, guys. Or they have some adverse event, or we stop returning the calls of the study because these studies require very good cooperation from the patient side. They have to come to the clinic sometimes, they have to fill questionnaires, they have to take the pills. So it's very highly, very high likely for them to step out of the study at some point. And the question is how you should deal with that. Should you analyze your data and outcome based on the initial number of the study participant, or based on the final number of the study participant? And there is ways to do it. You can do it either or, but the advantage or the best to do is to analyze your data based on the initial number, because you don't know why those patients get out of the study, maybe because of your intervention, maybe because of your adverse event. So ideally you should use the initial number to analyze. And how you know that? From reading the study, you just go to the methods section and see if they said intention to treat. So if they said intention to treat, then they are doing the analysis based on the initial number, and this is the ideal situation. What are the pros of the clinical trials? So as we said, they are balancing the confounders between the treatment or the exposure and the control or the no exposure group. So you have the confounder equally balanced between the two groups, so the confounders will not play a role in the final result association. And we can demonstrate this. If you have A and B, and you assume that A and we see the C is the confounder affecting A and B. But so in your study, this is the exposure group, this is the exposure group, and you have the same A and B in the non-exposure group. So you have both A and B in the exposure and the non-exposure group. And there's some kind of background. Okay. So, and there is exposure and non-exposure group. So if you are saying that we have the same number of confounder in this group and the same number of confounder in this group, this will cancel each other. So your results will be accurate, even though if there is a confounder, because you're doing the randomization. And if you do the blinding, you will avoid any bias that will result from the patient, or bias that will result from you or investigator or the analyst, because they don't know which is what. So they will not treat the people differently. It can establish temporal relationship. And as we said yesterday, time component. So you know for sure that the exposure happened before the outcome. So you can easily establish causality in this kind of studies, because you know for sure that the patient did not have the outcome at the very beginning of the study, and then they develop the outcome at the end of the study. So you can make a good association that the exposure preceded the outcome. And when this is the case, it's easier to make a case to say this is a causal relationship. What are the cons? It's expensive. It's really expensive, actually, and it's time consuming, because you have to pay sometimes for the patients, you have to pay for the investigators, ancillary stuff, sometimes medications. So it's kind of very expensive study to do, and require a large number of patients if you want to get good results, and not good for rare outcome. As we said yesterday, all the prospective studies are not good for rare outcome, because if it's rare, then start by the rare. Because if you start by the common, you will not get the rare. For example, if you have a chance of 1 in a million to get a disease, and you have a clinical trial with 100 patients in each arm, you have 1 per million chance that one of those 100 patients will develop the disease, which is most likely none of them will develop the disease in 2 groups. So it's not ideal to use it in the rare diseases. You should not use it in rare disease, because there's no chance. You're just wasting the money for no good reason. And loss of follow-up, and I would discuss earlier, what's the loss of the follow-up? It's a big problem in this kind of study, because you are following patients over time. And this is actually an ethical question. Your intervention also can cause adverse event, and this adverse events can cause harm to the patient. So there's always an ethical component of this kind of studies to make sure it's ethically appropriate and benefits outweigh the risk when you do this kind of studies. And we'll not talk about it probably right now because we don't have time, but most of the medication development process are based on the randomized trials. And there is actually stages, phases, phase 1, phase 2, phase 3. And one of the phases, the early phases, they test the safety, not the efficacy. There's a safety, then they go to the efficacy. And the safety is generally smaller, healthy population. So make sure that their medication will not cause a big harm to the patient. And then they go to the efficacy study with a bigger number of patients. So this is always ethics, research ethics should be part. And when you do actually a clinical trial in real life, it's a big thing. You have a big team, epidemiology, you have ethics committee, and you have investigator, you have patients, you have analysts. It's a big thing to be done, actually. It's very hard to do, and you will have all of this situation. So the next thing important for you if you want to start to work on the meta-analysis is to understand that what we call measure of association. So as we said, the research is there is exposure, there is outcome, and there is a study population. And your whole idea of any research is to trying to say that there is a difference in the disease status between the exposed and the unexposed. You want to say that the exposed group have, for example, more disease if the exposure was a risk factor, or less disease if the exposure was a treatment. So this is the whole idea of your research, trying to come to conclusion. So once you have your data, you want to give a number, a quantitative way to tell the people that, yes, I have an association, and this association is X. And the other people will understand from this X if it's significant or not. And this is what we call the measurement of association. And we're going to discuss the 3 main ones. Most likely you will not see anything else. Those 3 are covering like 99% probably of the literature that you're going to use in the meta-analysis. So the first question, you want to get the point estimate, then you want to know how strong the association is. So let's start by the most interesting and the most common, and the relative risk. So relative risk is a very actually nice measure, and ideally you have to try to get the relative risk all the time if you can in your study design, because there is many advantages for the relative risk. First, what's the relative risk first? I wanted to discuss very confusing topic for almost every medical student and every resident. It is the 2x2 table. This is called 2x2 table, and it is very fundamental component of any research type, big, small, whatever. And you're gonna get a question on this in your exams and in your boards and wherever you probably go to interview, they may ask you about it. It's a very, very high yield concept. And always is confusing to know where to put what, where to put the exposure, where to put the disease process. So always think of it this way. You have X and Y. X is the exposure, or it's the exposure. X is the exposure, or X is, generally speaking, in any mathematics, you have the X and the Y. Always the X is the, what we call independent variable that can control the dependent variable. So the X is the independent variable and the Y is the dependent variable. For example, if your curve here said the equation is Y equal X plus 2. So the X is the independent variable. So 2, the independent, not dependent on anything. The Y is the dependent on the X. So if the X is 2, the Y is 4. If the X is 4, the Y is 6. So always the Y is the dependent variable. So always remember this. This is the X. This is the independent variable. Always here is the independent variable, and always here the dependent variable. So always try to know that. Always this is the dependent variable, this is the independent variable. This is the X, this is the Y. So X is the exposure, Y is the outcome. That's it. And look here. So the relative risk is simply comparison. It's a way to compare the incidence in the exposed group versus the incidence in the non-exposed group. So to know the incidence in the exposed group, you have to incidence, what again, we discussed this yesterday. Incidence is the new cases divided by the population of interest. So the new cases are the cases with a disease, which is the A. And the population of interest is the exposure group, which is A and B. So A plus B. So this is the incidence in the exposed. Then you calculate the incidence for the non-exposed, like which is C divided by C plus D. Then you divide the incidence in the exposed on the incidence in the non-exposed. Like we said, the incidence in the exposed, refer to it as E. The incidence in the non-exposed, refer to it as F. So the relative risk is E divided by F. Incidence in the exposed versus incidence divided by the incidence in the non-exposed. And that makes sense because you want to make sure if they are, let's say that you get a relative risk of 1. What does that mean? That means that the incidence in the exposed is equal to the incidence in the non-exposed. So that tells you that the exposure has no relationship with the disease because it's the same in two groups. So if it's 1, it's not significant for sure. Oh yeah, it is 1. So there is no relationship. The exposure does not cause the disease because it is the same incidence in the exposed group equal to the incidence in the non-exposed group. But let's say that the incidence is above 1, more than 1. So let's say that relative risk is above 1. That tells you that the E is bigger than the F. So if E is bigger than the F, that tells you that the incidence in the exposed group is higher than the incidence in the non-exposed group. So the exposure has harmful effect because it increased the risk of the disease. So when it's more than 1, that tells you that the exposure has harmful effect. When it is less than 1, when it's less than 1, that tells you that the F is bigger than the E. So the E, the exposure in the exposed group, less than the disease, like the outcome or the disease or the incidence in the exposure group, less than the incidence in the non-exposure group. And that tells you that the exposure is protective because it helps to decrease the disease outcome. For example, a medication. So if it is than one in a medication, you will say, yeah, this medication is good. If it's more than one, then this medication is very bad because it could increase the disease, not decrease the disease. If it's one, then this medication doesn't make any difference compared to the control or to any other medication. So those are the, and this is, those simple principles are the principles of any big study. So as we said, if it's one, no association. If it's more than one, then this is a harmful or detrimental effect. Like the exposure can cause more disease. And if it's less than one, the exposure can cause less disease, like medication, for example. So this is what we call the point estimation. We got our number, which is the point estimation. It's more than one. This is enough to say this is the relationship? The answer is no. Why is no? Why the answer is no? I will go back just to the theory a little bit. So generally speaking, when you are doing a study, what's your purpose of the study? To apply this study to study population. Like for example, if I am doing a study about the effect of a statin on diabetes, let's say in Ramallah, I will not actually give a statin to like half of the people in Ramallah, and I will not give a statin to the other half. I will not do that for sure. I will pick a sample, 100 from will give the statin, and the other 100 will not give the statin. Then you will make a conclusion, and they will say that we concluded that the relative risk is 1.5. So that tells me that the people who take a statin has higher risk to get diabetes in Ramallah. But is this accurate? Can you say that? Like, can you say based on only on 100 people, 100 only 100, so 200 population, you can generalize that to 100,000 population? That doesn't make sense much. So this is why you need the p-value and the confidence interval. So generally speaking, also, so there is actually probably, I'm not sure if many of you guys got exposed to this or not, but I will give some kind of like short description what that means. So there's something we call alpha error. Alpha error is a very there is alpha and there's beta. We'll only talk about the alpha actually right now. So the alpha error that you conclude, like your study concluded, like as we said an example in the statin in Ramallah, you concluded that statin can cause disease. In reality, if we make a calculation for all the people in Ramallah, you are wrong. Your studies, you are wrong. So you are making what we call type 1 error. You are concluding that there is a relationship while in reality there's no relationship. So this is what we call alpha error. And always there is a chance of alpha error. There is a chance, like this association was not right. You are making wrong assumption, wrong conclusion. There's a statistical way to know what is the chance that you made alpha error in your statistics. The chance is the p-value. So if it's less than 0.05, that tells me that the chance that you did alpha error is less than 5%. So that tells me that the chance that you concluded there is a relationship between the statin and diabetes, while in reality there's no relationship, is only less than 5%. And this is acceptable. So if it's less than 5%, then this is acceptable. We accept it in the research and the scientific literature. So this is where the p-value came from. When they say p-value less than 0.05, that's what they mean. They mean that the alpha error chance is less than 5%. Then you can conclude that there is a relationship and we can accept what you are saying. So then what's the confidence interval then? The confidence interval, also the same idea. You have a real population and you have your study population. And to conclude that the real population has the problem that you are talking about, you will benefit from confidence interval. So let's say that you concluded that it's 1.5, and the confidence interval is 0.8 to 2.2. You know, this is how the confidence interval is, two numbers, 0.8 to 2.2. So what that mean? What that mean? So the chance, this is what that means. The chance, there's a 95, if you read 95% confidence interval, there's also 99, there is 90, but the most common practice, like 99% of the time, it's 95%. 95%. But you have to, just for you, when you read the article, just make sure it's 95% confidence interval. So if it's a 95% confidence interval, that tells you that there's a 95% chance that the real relative risk, like the real one in the real population, is between those two numbers. It's between the 0.8 and 2.2, because you can't get an exact number, so they give you an interval. It's so they can say that the real relative risk might be a number between 0.8 and 2.2. So what does that mean? That it can be 0.9 in reality, or 1, or 1.1, or 1.2. So so the problem is here in this example, if it's 1, if it can be 1, if it can be 1, then 1 means no association. So if the confidence interval cross 1, like always look at the confidence interval. If it's crossing 1, like if it's 0.5 to 1.5, that tells you that you cannot make conclusion. You cannot say there's a statistically significant association, because the confidence interval cross 1. So it can be 1, the real value. If it's 1, there's no association. So 0.5 to 1.5, no association. 1.1 to 1.1 to 2.2 is a significant association, because it does not cross the 1. So always read the confidence interval and see if it's cross 1 or does not cross 1. And as we said yesterday, not all the study types can provide you with the incidence data. Only, like case control, for example, can only provide you with the odds ratio. And the good thing about relative risk and the incidence data, that you can do something called actually number needed to treat, number needed to harm. So to do that, you have to, and this is something, so, and this is in theory, for example, if you wanted to give, for example, like if you give any medication, for example, statin, you want to know if you give 100 patients the statin, how many cardiac events can you prevent in 1 year? And you will not get this information unless you have incidence data. So relative risk is even also helpful for some other stuff, because this will help you to build a guideline after that, because you will know from the guideline that yes, the guideline based on numbers, that if you treat 100 patients, you will benefit 10, for example. So this is a very good medication. So let's just advise people to take it. So this is how they generate out guidelines. Also, they look how many people that you can help if you are providing medication, and that is incidence data. So you have to have incidence data to do that.
Hazem, this is great. There's a comment from Yasmin to go over the confidence interval when it includes 1. And what does that mean?
Sure. So let's try to talk about it again. So let's say that you have confidence interval 0.9 to 2.3. So that tells you that the real like you have a relative risk, let's say, of 1.2. This is for your study population. You calculated it from your sample, like the 200 patients that you got. But when you make the statistical analysis, it's going to give you confidence interval. The confidence interval is the real value, a real population, because 1.2 is an estimate from your small sample. It's not the real value. It's because to know the real value, you have to test every single patient in your population. Like if you are trying to say in Ramallah, you have to test everyone in Ramallah to say this is the real value. But you cannot do that. So you just use another way, which is your sample value. But your sample value is 1.2, but the software will give you the confidence interval, will tell you that your real value might be, it is not 1.2, it is something between 0.9 and 2.3. So this is your 1.2. This is 1.2. So your real value, the software will tell you it is something we don't know. We cannot know for sure. We have to test everyone in the Ramallah population to know the real value. So we cannot do that. So the software will give you an estimate. Oh, your real value will be something in between 0.9 and 2.3, something in between. I'm not sure what's the real value is, but the software can tell you that the real value will be something in between those two numbers. So if the real value is between the 0.9 and 2.3, so that tells me that the real value can be 2, can be 1.5, and can be 1. Can also be 1. So if it can be 1, so if it can be 1, and 1, as we said earlier, means no association. So if it is can be 1, that tells me that it can be no association. And if it can be no association, then you cannot say a conclusion that the relative risk or like the exposure associated with more outcome. You cannot say that because your real value can be 1. So, but let's say that the software gave you a confidence interval of 1.2 to 2.2, and your value is the same, is 1.2. Like let's say 1.4. So your estimated value from your study population is 1.4, but the real value the software give you, it can be something in between 1.2 to 2.2. We don't know, but it can be 1.3, it can be 1.5, it can be 1.7, it can be 1.9, but it cannot be 1 because it starts from 1.2. It cannot be 1. So for sure, there's a significant relationship here because the value cannot be 1 at all because it starts from 1.2. So it does not cross 1. So that's the whole idea of when the confidence interval cross 1 or does not cross 1. And just as like, this is the concept of it, where from it came from where. But in real life, we just look very quick to see if it can cross 1 or not to decide if this is a significant relationship or no significant relationship. So I hope this explained the confidence interval. And I know it's kind of a very like complex concept, but this is like how they came with it. So the next thing is the odds ratio. So we talked about the first one, the very famous one that we like is the relative risk because also give you incidence data. Sometimes this cannot be done, like in case control studies. So you have to get some other estimate, which is called the odds ratio. And the odds ratio, again, just as a refresher, here we have 2 by 2 table. The X is the independent variable. It's on the left side. The Y is the dependent variable and the disease or no disease. So this is the X, this is the Y. Okay. Then we will have to try to understand. So what's the odds ratio? Odds means probability. Probability. It's only simply it's a probability thing. It is the probability of the disease in the it is the probability of exposure in the diseased patient versus no diseased patients. Like just like for example, if you have 4 patients here and like one patient here. And then you have, let's say, you have 10 patients here and 10 patients here. So the odds, like the probability of exposure in the disease population is 4/1. So it is 4. It is high probability, 4 times. So the odds of being exposed in the disease population is high, 4. And the odds of being exposed in the non-disease population is 10/10, which is 1, which is low. The odds ratio divide 4/1, so it is 4. So it is significant. So that tells you that the odds of being exposed, or the probability of being exposed in the disease population, is higher 4 times than the odds of being exposed in the non-disease population. Because in case control studies, you divide your population by the disease actually status. You go to the disease, you get 50 patients with disease and 50 patients without disease, and then you see how many exposed and how many non-exposed, and then you don't have incidence data. So what you do, because you started with a disease, you cannot have incidence data because you started with diseased patient. To have incidence data, you have to start with a healthy objects and then see how much disease they developed. But in case control, you cannot do that because you're starting with a disease population. So you have to see in the disease how probability was of them exposed to smoking. Like, let's say the disease is lung cancer. So the probability of being exposed to smoking in the disease population was far higher than the probability of being a smoker in the non-disease population. And this is how you make the odds ratio. So it's kind of like, there's no incidence data, but it can give you an estimate, because in simple language, if you have more smoker in the disease population, that tells me that smoking is associated with lung cancer. So that's how I think. So it's a very good walk around when you don't have incidence data. It's a very good actually the estimate, because this is what you can do. You don't have incidence data. So what you can do just to see the probability of being exposed in the disease population versus the probability of being non-exposed in the non-disease population, and then you can make your calculation. And there's a way, you will see formulas to do it. Like the fast formula is just multiply A by D divided by multiplication of C and B. So there's a way to do it very fast actually, and the software can help you with this, but this is the principle of it. The problem, so sometimes the only thing that you can have when you are doing logistic regression is the odds ratio. And the studies which using the logistic regression as a way to estimate the outcome will give you odds ratio. So it's the only thing that you got. So you have to deal with it. And sometimes it's overestimate the risk. So there is some drawbacks for it, but still, I think it is very helpful measure if you know how to use it. The third one is a complex one actually. It's called the hazard ratio. And the hazard ratio in simple language. So this is, you will learn about this actually maybe in statistics. This is called Kaplan-Meier survival curve. So the Kaplan-Meier, in simple words, you start by no one have the disease, no one having the disease, like 100% of them are healthy. And then at 80% here, 80% are still alive. We are talking about mortality. So you start by so there is the intervention group, and this is the control group. So you start by 100 objects in both groups. They are healthy, they are alive. After 5 months, let's say, 80 are alive, and here still 100 alive. So the intervention group are doing far better than the control group. And then you go here, you see there is 20 alive, and here there is almost 70 alive. So you just continue to follow up over time. So this is the intervention group, this is the control group, and this is very important concept. So So what you get from this, you can calculate something we call hazard ratio. What's the hazard ratio? The hazard ratio is the risk of developing the disease every single year. Like, for example, it is the risk to develop heart disease if you take this medication. The risk of developing heart disease or die every single year merits death. Die from heart disease in this group, it is, let's say, 10%. So there is 10% every year for you to die from heart disease in this intervention group. But there is a 20% the risk of dying every single year. If you live 1 year more, there's a 20% like chance to die. So in other words, if you start 100 population, 20% chance. So the first year they're going to be 80 because 20% died. And then 20% of 80 is 64 almost. So 16 died. And then like it's a like logarithmic thing. So it is going like logarithm. And ideally, it's a complex, actually, it's a complex statistics, but what they do, something we call in statistics Cox regression. You don't have to know about it right now. And even I don't think you will encounter many hazard ratio when you do your meta-analysis, but you will see it just. And your mentor during the research projects can help you to understand the statistical approach, how to address the hazard ratio. But this is the idea of hazard ratio. So meta-analysis, our topic, like why we are doing all of this to start to put you on the first few steps to do meta-analysis. So meta-analysis, it's like systematic review actually, but it's a quantitative. So there's numbers. So there's a numbers. Systematic review, you can do something called narrative review. You just write, you discuss, you bring opinions, you summarize for anyone the literature. And you can provide some critical thinking and further steps. Meta-analysis, you provide summation, combining the literature in numerical way, quantitative way. So you will actually give a quantitative measure, as we discussed earlier. You can easily connect your exposure to outcome, but you have to give a number. And the number and with a confidence interval, so anyone in the world can understand, just looking at your results, can understand if there's association or no association. Meta-analysis can do that, but instead, all the studies, we are doing this on individuals level, like we are bringing sample number of 100, 200, 500, we are doing it at the individuals level. And meta-analysis, we are doing at the study level. So we are bringing studies, like we're bringing like 10 studies this say, and we're trying to combine the effect of those 10 studies into one single number. And this single number can help you to understand, because the problem with why we are doing this actually, why like we are doing this, why we want to bring different studies. The main reason is because the studies can be conflicting, simply speaking. You can get one study saying, oh yeah, there's association between X and Y. And the other study will say there's no association between X and Y. Then who to believe? Should we just do like single sum? You just sum them together? No, there's a statistical way, meta-analysis, to help the evidence-based, to give you some kind of a systematic way to make any like summation of this evidence into one single number, and depend on that number, you can tell if there's any significant association or not. So to do a meta-analysis, and my colleagues Mohammed and Aziz will guide you through this, and this will be the focus of the next few weeks lectures, is you start by research question, then you have to have a criteria for inclusion and exclusion, then you do data extraction, then you aggregate the finding, then you evaluate for homogeneity or heterogeneity, and then you do sensitivity analysis. So first, you have to have a question. This is one of the biggest actual problems sometimes, to have a question, to have a good question, so it can be published. Then after the question, you can search for the like papers that will match your criteria for inclusion or exclusion. For example, you can say, oh, I only want randomized trials. I don't want to do any observational study. I want only experimental studies. So then you can put in your criteria in the research only experimental studies. Search for them, get them. And you have to explain how you did your research to make sure that you are doing it in the right way without bias. You have to explain in your paper how you did it, what you have done, and then you have to provide something we call the Prisma chart. Like there's a way, my colleagues will talk about it, how you decided which is what. Then you start the data extraction process. And here's important, the skills that you know about the relative risk, the odds ratio, the study population, how you can collect this data from every single study and make it in a simple, nice way, nice table, so you can use it for your analysis. And my colleagues also will guide you through the process with example. Then you will put your numbers into a software to get your data results, like the single number that we talked about. And after that, you have to test something we call heterogeneity. And we discussed this earlier a little bit, which is you want to make sure what is the reason for the differences between the studies. For example, if you have studies that will say 3 of them they will say there's effect, 2 of them they will say there's no effect, 2 others will say harmful effect. So you have to understand why there is heterogeneity and how you should handle that. And also my colleagues will tell you how to handle that in a statistical way. And then you do something called sensitivity analysis, which is a way for you to make sure that your results are valid, even if you withdraw one of the studies. And also probably Aziz or Muhammad will talk about this in details, how to do the sensitivity analysis. So the hard question is how to get research ideas. And I can tell you it's not an easy question, because to make a research, you have to have always a good question. Because if it's not a good question, or it's out of date question, or it's not relevant question, it will not be published. So you wasted your time and your mentor time, for example. So to get some of the ways to get a good idea, ask your mentor. If you have a mentor who is excellent in a field, they will be able to understand where the gap is, because again, all the research is about filling the gap in the literature. You are trying to answer a question that is relevant to clinical practice, but there is not enough studies, or there's not enough evidence about the right answer. So you are trying to bring the right answer to fill the gap in the literature. So you can ask your mentor, oh yeah, did you come across any thing that you think that if we do meta-analysis will answer a question to help build a guideline, for example, and they will be able to help you with that. Or you can start by doing a research. And this is, if we have time, we can show you an example how to do research for ideas. It is also not an easy thing to do, and also should be guided by your mentor, but also can give you some kind of understanding how to generate those meta-analysis. Sometimes one of the tricks, you can look at the conference abstracts, actually, because the conference abstracts, they have some of them actually, they will throw a meta-analysis and they will not do it full text. So you just give the idea, it's a good idea. You can make it, search for it, see how you can tweak it a little bit, and then you can make a full text meta-analysis from a good research conference idea that was presented in the conference. And you can also, when you are reading, for example, UpToDate, you will see in the UpToDate, they will say there was no study done to compare X and Y. So you will go and check if there's any new literature in X comparing Y, then you can come up with a new idea. And that happened to many of my friends. So you can always get ideas. It's not easy, actually. It's one of the hardest part. And there is many ways to do it. So you have always to make sure that you have a mentor, probably the first thing, and you have to help your mentor actually as much as you can by doing your homework. And to do your homework, you can use any of those 3 tools to do your homework to help your mentor as much as you can, because you know your mentor does not have much time sometimes. They have many other things to do. So if you want to be proactive, and you have to be proactive if you want to publish anything, you have to work with your mentor very closely and try to bring them some helpful resources so they can guide you through the process. We'll talk about, if I'm not sure if we have a time, I don't think we have much, but well, just one more thing, and we'll go just very quick about the example. One more thing, you as medical student, resident, or early career physicians, you have interest in a specific specialty. Let's say here, the interest is endocrinology. So endocrinology, you have to go and search for every single conference that will be done this year for endocrinology. Then you have to list them, say, what's the conference name, when it's going to be done, when they will accept abstracts, what's the fees, what the registration looks like. So you have to plan ahead that I have 10 conferences, potential conferences that I can submit my abstracts to. And once one may say, abstracts, who cares about abstracts? Actually, you should care about abstracts. And there's outstanding abstracts. You can get an award actually from the abstract. It can be shined on your CV. And as a student, as a resident, it's always good to submit to those conferences, because if you get accepted, you can go to the conference. And I can tell you, it is a phenomenal experience. You will meet people, you will learn about the field, you will see experts, and you have something to present and discuss, not just going for visiting or just for tourism. You're just doing something helpful. So always make a calendar of the upcoming conferences, local conferences, national conferences, international conferences, it doesn't matter. Make a list, start to see how you can submit to those conferences your abstract, and always mentor. You can ask your mentor. Let me just stop here and let me see this card, and then just go to here very quick and go to something we call Web of Science. Web of Science is one of the paid services many of the universities provide. I think there is ways even in Palestine to get it. You search, for example, diabetes. You do search, and then you want to see what's the highly citable papers. You want something that is hot topic. You just click hot topic, and then you want to click 22, 21, year 21, 22. You do refine. Then you will get, if you look here, you will see how many citations this topic got. This paper got 1,000 citations. And as we said yesterday, just again, citations means that someone took this paper as a reference. And that tells you that this paper is important and impactful in clinical practice. So if you do a meta-analysis on the same topic, most likely you will get many citations, and most likely you will have an impact in clinical. So you just take a look here and see, oh yeah, there's empagliflozin in heart failure. Oh yeah, preserved ejection fraction. There's almost 500 or 600 citations on this one. It's a New England Journal of Medicine. Okay, let me click on this, for example. Yeah, you can just then download the article, and then you can, oh, let's see empagliflozin. You just start to see, to search for it again. And then you can say, I want heart failure. So you can click title, and I want the title that said heart failure. So you just search. Oh yeah, you see there's 4 studies only, because we said that we need the highly citable and the hot papers. Let's say that we're gonna remove the hot papers because we don't need it right now. We need just only to see how many papers. And you have to search if there's any meta-analysis actually done or not. You just search if there's meta-analysis. Oh, there's nothing in this page. You have to keep scrolling and keep searching if there's a meta-analysis was done. It was no meta-analysis was done, and there's very good number of citations, as you can see here in this topic. Oh, this is a good topic to start. You talk to your mentor and ask them about what they think, and they can tweak the subject for you a little bit, and they will help you to formalize a plan and start to do meta-analysis. So, and you can skip all of this and ask your mentor very beginning. Sometimes they have some kind of ideas and they don't have time to do it. So they can probably guide you through the process. But it's good to know the literature about the topic that you are doing, because this is the meta-analysis. We are trying to summarize all the related literature to answer the question. And you cannot ignore any part of the literature if you want to make a valid research paper that will help and impact the clinical practice. Probably I will stop here and see if there's any questions, because we have only a few minutes, and go from there.
Thank you, Hazem. This is really fantastic. And I think, you know, no matter how many times I hear about statistics, I always learn something new. I remember the days of medical school. This was difficult topic, but you know, this is really very essential. This represents the essence of biostatistics. And if you want to be a good researcher, you have to really know these concepts. So I'm gonna send the recording for this session also, if you want to review it again. I think this is really fabulous, especially the last part. This is really big secret that Hazem gave to you, how to look for topics, and will be helping you picking up topics to work on meta-analysis in the near future, inshallah. Now, questions. Let me look. There was a question about how to calculate p-value and when to calculate it, before or after conducting the study.
So actually, when you do a study, it will be calculated always. When you, or like when you do any analysis for any outcome, they will give you the p-value right away.
So it will be after doing the analysis. And my take on the p-value, there's a lot of statistics involved into it. You will not be doing it manually. Usually you'll pick a software, you'll input all your information in that software, and it will simply tell you, do you want one-tailed or two-tailed p-value, and calculate it for you. But in general, p-value, it tells you simply that you're not dealing with type 1 error. And the likelihood for type 1 error is less than 0.05. This is an arbitrary number that came, you know, just they decided 1 out of 20 or 0.05 is the significant value. Less than that, it is significant. More than that, there's a chance for type 1 error. There's a question from Dr. Sohail Amar. He is a rheumatologist in, I think, Hadassah. Sohail, Dr. Sohail is asking, and this might be a little bit difficult question. The question is about real world and registry studies, explaining how about retention rate and persistence time. This is becoming on fashion and trendy in rheumatology research. So the question is about registry studies and the retention rate in registry studies.
Like registry, like my understanding, like I think there is registry for like rheumatology, probably Dr. can help us. And there's oncology registry, that you have a big database where you have patients with a disease. I think they are helpful. And even in the United States, actually, I was part, and I'm going to be part of the research in Vanderbilt, that we are using a registry. Because the good thing about registry, you have the data already, so you can do kind of like more cross-sectional studies, but they are probably good to give you the hypothesis generation, because you can start with it. It doesn't cost you much money. You just apply for the IRB process, get it done. You start with your registry, you give, and sometimes can give you some insight that you will not actually get if you are planning or thinking about it. So sometimes they can give you some answer that you were not looking for, and it can help you with your hypothesis generation. And it's a valid, I think, research, and there's very big studies here in the United States that have registries, and they're citable, and they are providing some kind of outcome to the literature.
Okay. Another question from Amr is asking, Amr and Lama, they're asking how to search for conferences.
Confounders? What?
Conferences, like conference.
Oh yeah, conferences. Like for example, let's go here. Actually, there is, let's say, endocrinology conferences. So there's a website actually. So there is a website that will, oh yeah, you get ACE. Oh, there's an ACE conference. I got one. This is one. This is an ad. You can go to meetings and events, for example, in the endocrine website. You can see that there is many events that is listed there. You can just click on one of them and see the calendar. There's a worldwide endocrinology calendar. You just go to the worldwide and see how many conferences. This is all of them as conferences in endocrinology. So it's kind of very easy, to be honest with you. Like here's like they are giving us at least 10 conferences in endocrinology, and there's as we said, sometimes it will not, like especially the local or the national, it will not show up here. So you have to go in the Facebook actually and search for conference in Facebook. It will actually, it's a valid way actually, even it looks very simple, but it's a valid way to do it. You just go there. So it's easy to look for conferences, and the most important thing to put them, as I said, in a calendar, so you will not miss the deadline for the abstract submission. This is important. This is always the problem. Always we miss that part. We don't plan ahead, so we just end up like not submitting our abstract because we did not know upfront that this is the deadline. And the hard deadline, the first deadline, sometimes there will be no fees. If you are applying too late, you have to pay more, and it's harder to accept.
Mm-hmm. Okay. Another question from Abdul Latif is asking, what's the effect of intention to treat on external and internal validity?
That's a good question. So intention to treat is affecting the external validity of the study, because if you do intention to treat, you are using real world, because in real world, patient can stop taking the medication and they can stop taking it for many reasons, adverse event or anything. So if you do intention to treat, like you are treating those patients as they are assigned, like a real world, like it's like mimicking the real world, then this will increase your external validity, because this can be applied to the real world more, because it's more similar to the real world compared to the other type of analysis.
They have a lot of, thank you, Hazem. Thank you for this excellent session in the chat. It was really excellent.
And there's also, I think there is a hand, I think Mohammed Hussein hand. Yeah, he can, please go ahead and
go ahead, Mohammed. Unmute and ask your question.
And meanwhile, there's a question. Actually, there is a question, very interesting question. There is a question how you can do randomization in surgical trials. There's something, probably you can search for it more, sham procedure. So there is like a procedure, but does not do anything. You just do a procedure, injection, for example, without any affecting the patient. And this is more in the pain medicine trials. It is interesting, actually. You can search for it, how they can do sometimes a procedure that the patient will be under the impression he got an intervention. In real life, he did not.
Okay. A question from Mohammed. Can you opt meta-analysis in the Web of Science search tool?
Can what? I'm sorry?
Can you opt meta-analysis in the Web of
yes, you can actually say review, actually. Yeah, so you can do it either two ways. I will show you probably 2 ways. So there's here, if you go here, you can actually, in the title, because most of the meta-analysis, they will mention meta-analysis in the title, most of them, or the body, or the abstract. So you can just go here and see the title and say meta-analysis, for example. So when you search, they're gonna only just bring you the meta-analysis. There's another way. You can say review article, but when you say review article, you will not see all the meta-analysis. Sometimes they will not define it as a review article, even though it is a significant, like even though it is a meta-analysis, it will not show up in the filter of review. So I recommend to do it twice, manual and review, so you can get most of the like the whole idea.
And Riman is asking, how can we be sure that a study we want to take it as a reference I think Riemann is referring to meta-analysis. In our research is a real one with no bias.
So that's a very good question. Part of the meta-analysis, probably my friends will talk about it more, to assess the quality of the study. There is part of it, like part of the meta-analysis, to say high risk of bias, no risk of bias, what's the quality of the study. So it will be part of the process. Actually, you have to mention it in the analysis.
Mm-hmm. And Bilal Jawabri is asking about the confidence interval when it's less than 1, but it does not include 1, like minus 0.2
So,
or 0.2 to, let's say, 0.7.
exactly. So if it's minus 0.2 to minus 0.7, that tells me that your real value of relative risk is between 0.7 to 0.2. So that's significant relationship, but in the other direction, as we said, it's more protective effect.
Okay. And Ibrahim is asking, can we change the association relationship in cohort or case control studies to causative relationship?
So there is actually a criteria. So here's a good question, actually. The statistical analysis give you only if this association, what we call association, is statistically significant association. That's the whole idea of the statistical analysis, to give you there is a statistically significant association. To make a causation, there's a criteria, actually. I did not go through it right now, but there is a criteria. There's 8 items. You take a look into those items. One of them is temporal relationship. The time is one of actually the biggest one, actually, the most important one. So to make assumption this is a causative, it's more about not the statistical analysis, but it's more about it's a temporal relationship. It is making sense, consistent with the literature from before. There is a criteria. You can search for it if you want to make a causation. But generally speaking, studies don't tend to like say causation, but they can just give you some kind of agree with the previous literature, give you some kind of like this is mechanistically or mechanism wise, yes, can be causation. So to make a causation is not easy, but you can, but the statistical analysis that you are doing is telling you only answering the question is statistically significant association, and to go to causation you have to go through the criteria.
Mm-hmm. And I'm sorry if I did not go through all the questions. One last question from Dima. She's asking about multiple linear regression for intercept of equation. Is it the same or is it different for exception?
For exception, like I want to ask you for multiple linear regression. Yeah, it's the same. It's the same. But there you actually, so here's the thing. In the linear regression, you will get something called factor. You will get a factor, and then you can convert that factor to odds ratio. So there's a confidence interval for the factor, a confidence interval for the odds ratio. And it's the same principle.
Okay, excellent. Thank you, Hazem. Thank you, everybody. This was really very informative session for myself, and I think or also for this group. And I appreciate your time. Have a great night, everyone. And we'll meet again next Saturday. Muhammad Mhanna will be our speaker. And I am very thankful for Hazem for his time and effort. And have a great night.
It's my pleasure. Thank you so much.
Thank you.
Bye.